good afternoon. We come to that phase, right, where we've done our best to keep you around. We lured you with cookies out in the hallway, and hopefully you were able to enjoy the afternoon sessions and get back. And now it's just kind of the best for last, right? This is the coup d'etat. And by that, of course, I mean the fancy snacks and beer and wine that await you after John's comments. But we're really humbled. Everybody in this room knows LA Care. They know at least the name John Baackes. Good, bad, or indifferent, right, John? And the just the impacts that LA Care and John have had on this community are just outstanding. Largest public health plan in the country, 2.5 million covered members, but over 400 supported projects aimed at strengthening the safety net. So if you've met John, you obviously cannot question his passion for his work and the impacts that work has on the community and the population. And so with that, I'm going to just sit very quietly over here and would ask you to welcome John for his comments.
Thank you. Well, thank you all. I always love being the last speaker who stands between you and the bar. So I will be succinct. And my compliments go to State of Reform for putting together such a rich agenda of topics and highly qualified contributors. It was really a great conference. I was asked to give and I'm going to read, which I normally don't do because I only have 15 minutes. So I was asked to give my perspective as CEO of LA Care on future health policy landscape in Los Angeles, as well as our recent work at LA Care. As far as policy is concerned, I have two major concerns about the future. My perspective is informed by our position as the largest Medi-Cal managed care plan in California with 2.7 million members, over 2.5 million of them Medi-Cal beneficiaries. Every fourth person in the county is a plan member. In the last 20 years, Medi-Cal managed care plans have been tasked with assessing the health status of all our members. We have become acutely aware that the so-called social determinants of health are the most significant determinant of a person's health status and their ability to improve their health. I prefer to refer to them as barriers to better health, barriers that we have the ability to overcome if we're willing to do the work. I've come to view our role at LA Care, along with our participating providers, as social justice advocates. COVID showed us in stark terms that inequality is a life and death matter. The people who are our members were infected more, hospitalized more, and died at significantly higher rates than people with more resources available to them. People of color, which make up the vast majority of our members, are included in that cohort. Yet the truth of the matter is we have as policy, from the inception of Medicaid in 1965, funded it at a fraction of the real cost of care because it was a program for poor people and we could get by with a minimum appropriation. Today, 57 years later, and with a more progressive view, Medi-Cal still pays about 60% of what Medicare pays providers and less than half of what commercial insurers who support the employer-based and individual markets pay providers. And we wonder why there are health disparities in Medi-Cal beneficiaries. If you were in Hector Flores' session this morning, he gave an example of the reimbursement for a medical exam is $42 for Medi-Cal, over $100 for Medicare, and $150 for commercial. As a result, we have a two-tiered provider system. The most vivid example is at academic medical centers providing critical tertiary and quaternary care do not all participate in Medi-Cal because they cannot operate on Medi-Cal rates of reimbursement. I'm pleased to say that LA Care, we do have contracts, though, with UCLA and Children's Hospital. Among those hospitals and doctors who do contract to serve Medi-Cal members, there are inconsistent levels of reimbursement. Some providers qualify for additional funds in addition to LA Care's reimbursement. It is often related to their status as a public or private entity, or their caseload, including those providers that provide free care to the uninsured. Those providers whose case mix is heavily Medi-Cal operate on razor-thin margins and are always at a disadvantage in recruiting talent compared to providers with a more lucrative mix of patients. The whole process of developing Medi-Cal reimbursement rates and the additional funding sources available to some providers is as clear as mud. Medi-Cal funding, and indeed CMS funding of Medicaid, is long overdue for a transparency fix. My biggest concern is that the community physicians who serve 63.5% of our Medi-Cal members receive only the base rate for their services. The primary care docs do get Prop 56 money on 21 codes, but that pot of money, based on a smoking tax, is shrinking, and the specialists get no additional funding. With the end of COVID supplemental funding for a host of services and the material increase in the cost of nursing, the overall impact of inflation, and the fallout from an impending recession, we're entering uncharted waters. I fear that providers such as solo and small practices serving Medi-Cal members are going to be forced to retire or accept salaried positions outside their community. Community hospitals, which are the only available healthcare provider in many healthcare deserts, may fold. There are no replacements waiting in the wings. Added to the financial concerns, we are about to begin a process that will impact millions of Medi-Cal beneficiaries. When the public health emergency ends, there will be a 14-month period to redetermine each beneficiary's eligibility. It will have been 3 years since the last annual exercise of this process. We've estimated we will lose 300,000 members who will have moved, earn above the Medi-Cal ceiling for eligibility, or fail to respond to the notice. I think it's time for the ecosystem of plans and providers serving the safety net population to come together as a system of care, not as a system of competitors, which is what we are now, and develop a plan to bring to the California legislature to help us develop a more transparent and equitable distribution of resources so there is more parity in provider reimbursement regardless of which plastic card you have in your wallet. My second concern is about CalAIM. It is a large, Godzilla-sized set of initiatives that are welcome and badly needed because they recognize that social services need to be integrated into the care plans of Medi-Cal beneficiaries. And my kudos to DHCS for getting this package approved by CMS. I think we are leaders in the nation in this experiment. But my concerns are fairly simple. CalAIM comes with a ton of new administrative tasks and data collection. Is it all necessary? It's going to put more burden on our providers who are already at burnout stages. We still don't have the results of the 2 demonstration waiver programs, Whole Person Care and Health Homes, that just ended 9 months ago. So we're not basing CalAIM on any of the learning from those demonstrations. Community supports are supposed to pay for themselves in reduced Medi-Cal spending on healthcare services. But Medi-Cal funding is deeply discounted compared to the cost of care. And we are expected to save discounted dollars by buying community supports at retail prices. I don't think it will work. There's a lot of one-time money for incentives and infrastructure, and that infrastructure may not be sustainable after this money is gone. At LA Care, we view CalAIM as a partnership between us and DHCS. We do not see ourselves as merely vendors. And we will do our best to make CalAIM work, offer our insights and experiences to improve the program. After all, we and our providers, not DHCS, are on the street doing the work. So the next 18 months will be critical for the providers and plans serving the safety net and will require extraordinary cooperation between us all to confront these challenges and provide the best for the beneficiaries. I was also asked to comment on what we're doing at LA Care. I'm particularly proud of two initiatives we have supported for several years now. For those of you that were in my partner in crime here, Dr. Richard Seidman's session, you heard about elevating the safety net program. It's all about workforce development, and it includes three features I'd like to discuss. We currently fund 8 medical school scholarships a year at UCLA and Charles Drew. We've funded 40 scholarships in the past 5 years and have committed to continue for another 5 years. We ask the schools to select the scholarship recipients based on their interest in returning to the communities of origin to work in the safety net. I'm pleased to report of the first 40 LA Care scholars, half are women, and all but 2 are students of color, an important pipeline cohort to match their future patients' race and ethnicity. We've offered grants of $125,000 to clinics and practices serving Medi-Cal members to bring new PCPs into the safety net, and we will retire up to $180,000 of medical school debt if the docs stay for 3 years. Since 2018, this program has brought 144 new PCs to LA County. In cooperation with SEIU, we have trained 5,200 in-home support service workers who are often family members with no training. One of the trainees told me that he was his mother's caregiver and that this training had taught him the difference between his role as a son and his role as a caregiver, and as a result, he was better at both. I am convinced that this training saved lives during the early days of COVID by keeping vulnerable Medi-Cal beneficiaries at home instead of in long-term care facilities where residents were ravaged in the early days of the pandemic. The other initiative I'm proud of is our 10 community resource centers spread across the county that we've developed in cooperation with our plan partner, Blue Shield Promise. Eventually, we will have 14. These are health education centers with all classes open to the entire community at no cost. For our members, we have customer service reps for walk-in service. We have community health workers whose caseload is in the surrounding neighborhood, encouraging home visits with our most vulnerable members. We have hours for social service agencies to be on site so members can sign up for programs they're eligible for. And we will soon add technology bars so members without high-speed internet service can use our facility for virtual appointments. In closing, I believe LA Care has a unique role in our community. We are a not-profit public entity where the leadership lives in the community, and we have no shareholders to reward. Therefore, I see LA Care as an advocate for our members and participating providers to improve the quality of the lives of our most vulnerable fellow human beings. Thank you.
Thank you for those comments. Similar to previous sessions, we'll have microphone available to anybody who wants to ask a question. And I'm really appreciative of John to be able to come and share perspective kind of from your vantage point to the LA Care. Obviously, your experience has been outside of California as well. And so you've seen kind of dynamics that exist in other places and things like that. So I guess to start, really, I would love to pull on the thread of your concern about Well, it's almost a balancing act between acknowledgement of the need for social services to be integrated in, but also the concern about how it is folded in, what's the appropriate way. I want to get a little bit deeper into, what are some of the specifics that LA Care and Los Angeles and California at a larger scope are going to have in trying to integrate some of those organizations and services.
Well, I think...
Yeah, you're on.
Well, one of the reasons I'm concerned that we have launched off on CalAIM without looking at the results of whole person care in health homes is if we're going to do the integration of social services with health care, we're really going to be relying on care managers, and I have a few over here, and community health workers. And what we learned from whole person care is that we only need one. We don't need a bunch of them representing each of the silos of social services or health plans or providers, because we had people in whole person care who would say, stop calling me, I'm overwhelmed. So I think the idea that we have to come together again as a system of care, not as a siloed system of providers, and agree on one person that's going to be the care manager or one person that's going to be the community health worker, so the member can build a relationship with that person, because that's really the best way for us to help that person go forward.
Do you think that there is a variability to that approach, or do you think that there is a kind of right-sized solution? Is it something that sits at the provider point of care level? Is it something that sits up with the plans? Is it something that the counties or other jurisdictions need to engage in?
Well, I'm biased that it should be placed at the plan, only because I did that before in a plan that I ran in Boston back in the early, what do we call them, aughts, the first decade of the century. But it certainly can be done in the provider office as well. I think there just has to be an agreement and an understanding and a division of resources that has the resources in whichever place it's going to be, not duplicated and not in competition with the rest of the team.
Great. Oh, question right here, and there's a mic running to you right now. And again, just helpful for context, your name and
Okay. Hi, John. It's Pam Oakler, and my question is, the way the enhanced care management benefit has been set up, that is the goal, to have the lead care manager be the person who navigates the individuals throughout the whole continuum. So is your concern that that lead care manager is out in the community and not inside the plan? How do we better connect those two? Because that was the whole purpose of creating that benefit.
No, I agree with you that that was the purpose. As we're, 9 months into it, we're finding that the administrative burden that is placed on the CBOs that participate in this is slowing the ability for us to sign up new people and to achieve what you're talking about. So I would go back to my concern about the reporting requirements of this may bog us down in being able to accomplish what the goal was. And I agree with you, that is the goal. And it would be great if we can do it. I can tell you that DHCS has already admonished us that we're not enrolling people fast enough. And I said, well, we got 20,000 already. This was August. I said, what's your benchmark? Well, we don't know, but you're not doing it fast enough. So I think it's important that we give that feedback to them. And the big feedback is the CBOs are having a hard time adjusting to the administrative requirements, the billing, and many of them are small nonprofits who do not have a back office that can handle all of this. So I think there's going to be a shakeout, and I hope DHS listens.
other questions? I actually have one on that line, and it is the balance. By the way, quick reminder for everybody to silence their cell phone, please. Thank you very much. If there is that balance, right, because I don't think, and we've had this conversation a little bit, I don't think I hear you saying that there's no place for reporting or data.
Absolutely not. But, we've probably shipped 10 gazillion gigabytes of data to Sacramento. Where the hell is it? I think it's in some windowless basement storeroom. Thank you. So I think an evaluation has to be done, and I'm sure there's some consulting firms
I'm not aware
who
of
would
any.
glad to help them sort out what is the critical data needed to evaluate progress and make decisions about how to change things. And I don't think we have that discipline now. It's just like, how much data you have? Send it.
Send it. I know we've got question here and then here. Yep.
Hi, John. I'm Julia McConaughey from Coordinated Regional Care Division of Prospect Medical Holdings. We have partnered with your company to take on dual risk and manage the patients in conjunction with our contracted IPA partner. That has turned out to be a very successful Petri dish study, and I question if we are trying to do CalAIM to integrate the social determinants with the clinical and chronic care management. They're running parallel to us. They're not bidirectional. And we know who are the chronically ill patients who are exacerbated by their social determinants or drivers of health. I would suggest that we are the partners that should be providing that care in conjunction with our Partners in Care Foundation, so that we can share the data. We already know who those patients are. What do you think of that idea?
I love it. Joel, talk.
Let's talk more.
Let's talk.
Others? Eli, right back. Where you came from.
Hi, John. This is Noah Ng. I am one of your staff at LA
Yes,
Care.
I know.
I had a question. So much of the money that CalAIM is spending is on the coordination of members through a fragmented healthcare delivery system. What concerns do you have on how CalAIM further fragments the system by adding many different provider types and different services, each with their own maybe intake forms or accessing different accessing availabilities for our members? Any thoughts on the further fragmentation of the system and what we can do to address it?
Well, you brought up some of the things that are part of my objection about, not objection, but concern about the volume of administrative tasks that go with this. So if DHS isn't going to streamline it, I think we as a plan who's getting the funding and then distributing it among our providers, that we should take on that responsibility and try to have a uniform set of forms to fill out or whatever it is. And we have two plan partners, Blue Shield Promise and Anthem, and we have discovered over the last few years that I've been involved is that we should come together as three plans that are dealing with all of you and have similar processes and procedures, so you're not having to, you the providers, don't have to do something different with each plan. So I think you've put your finger on an important issue, and I think that's one where rather than go to DHS and complain, let's develop our own and show them how to do it.
Right here.
John, thank you for your talk and thank you for your support of primary care. I'm Chris Hirmore. I'm a family medicine doctor over at Alteus Family Care Specialist Medical Group. I guess I just want to kind of lay claim to, and I'm curious about your perspective on this, but as a primary care doctor, I guess the sense I always have is that while I appreciate the role that health plans and IPAs could potentially play, that my patients that I'm seeing in my clinic, I'm acutely aware of their needs and their social determinants of health and everything else that needs to be addressed. And I guess my sense is that really the work that I guess some people are advocating for happening at the community level or the health plan level. To me, it seems like it makes most sense to happen at the primary care level, and really, in more cases, having the primary care doctors in their offices being able to provide these services and being able to be paid for these services. We have the established relationships with the patients that are trusted. And I think the thing that I've seen in my different roles is that when the care managers from either the IPAs or the health plans reach out to the patients, that they don't know who they are, they don't have the established relationship, and that's where I think leveraging the relationship of the primary care doctors patients do have is a really important one. And so I would just kind of curious about your, I guess when you see the role of, you mentioned it should be one of us and not both of us, which I agree with, but when do you see the health plan being kind of the more important role versus the primary care doctor?
I think the health plan should be willing to step up and do that if the primary care physician or the primary care group doesn't feel they have the bandwidth to do that in addition to everything else. And then I think it should be a partnership, and there are probably examples where the plan could place somebody in the office to work there so that they do have more familiarity, as long as we have the volume to make it economically practical to do that. But I do agree both aren't necessary. The role of the IPAs is variable. There are some that really don't add value, and if Bill Bartholomew is here, he'll shoot me, but some don't add value, and some do. So each situation is a little different, but I do think we have to have an understanding that we're not both going to do it, and I would acquiesce to the practice that's willing to do it or has the bandwidth to do it, and if they're not, we'd want to be their partner.
And just curious about your thoughts around, I guess, payment reform from all the different payers to actually pay primary care practices and doctors to do this, because we only have, again, we work in a large Medi-Cal population, so we can't, that's currently not really paid for. And so it's something where we want to do that. It's something that we do on a limited basis, but in terms of, LA Care, other health plans coming together and paying primary care to do that work, because we have the bandwidth, but we don't have the funding. I think that's the challenge. I don't know,
Right.
Any hope that you have to?
Well, we have
make that happen?
we have some funding now through ECM. But remember, this funding, you have to sign up the member, provide the service, and then you get paid.
Right.
It's not like given to us in the capitation, and then we can distribute it to our contracted network, say, here are the resources. So if we could figure out a little different flow of how the dollars come, I think it would be easier to do it the way you were describing, to be able to give you the resources up front. Now they come, it's sort of fee for service as far as ECM is concerned. It comes after the fact.
Thank you.
I think we've got time for one more, if it's out there. And if not, I am going to offer John just a closing thought or kind of call to action again. I offered the same thing to the actual director this morning, and would be happy to give you the same opportunity.
Well, I would just say that, we try to be partners with DHCS, and we think the bigger issues about adequate reimbursement are not in their wheelhouse to do anything about. If we're going to fix the system and provide more resources for Medi-Cal, I think we're going to have to be talking to legislators, talking to Congress, because it's really crazy that a third of the population in California, who is most vulnerable, is starved of resources, and we're all trying to figure out how to move the few dollars around to get the biggest result possible. And I think we're reaching the end of the number of tricks in our bag that we can use to do that. And we just need to face the fact we're not adequately funding it from the get-go.
Very good. Please join me in thanking John for his time.